Good afternoon, everyone. This is live from SuVi Eye Hospital, third floor auditorium, SuVi Eye Hospital and Basic Laser Center in Kota. So we are in the third floor auditorium. We are having a webinar on retinal lasers, protocol, parameters, and practical tips. This will be presented by our Medical Retina Fellow, Dr.Yogesh Mangukiya, who is hailing from Surat, Gujarat. So I welcome Dr. Yogesh Mangukiya to come and throw some light on retinal lasers, protocols, parameter, and practical tips. Dr. Yogesh.
Good afternoon. Where I will be presenting lasers, parameters, and practical tips. So, I know from retinal laser but it's for having clinical scenarios. Not only use the India lasers and system. So what are the parameters? Usually when retinal photography we use the around 100 in seconds versus around power will be usually tightened according to the patient conditions when you and solution will be 1 month's device. For the photo laser, we usually use the 15 parameters and relation will also be 15 milliseconds and power will be less. And intensity will just open up the high range appearance on video. And for video, that also we use a low power low density device, and in that usually use a red one for device and space apart the one parts. And for that we use 100 to 100 microns and for size and this will be how will be the type as the photo images. It's 8 burns and usually like 1 watts and 2.5 watts.
So this is a nice table. So the most important thing I would like to elaborate is the grade of the burns is very important. So for PRP, grid and barrage, grid is obsolete nowadays. For PRP and barrage, we use grade 2 to 3, and the power can be different. So power depends on your media. Also, we can have grade 2 to 3 burns. So power depends on the media. Patient has a clear dense young patient or pseudophakic patient, or if it's a dense cataract, then we need to use more power. So it does not depend mostly on the power, it depends on the grade of the burn. We should aim for grade 2 to 3 burns. For focal laser, that is just visible burn. Grade 2 is whitish, yellowish burn, grade 3 is yellowish to grayish burns, and grade 4 is chalky white burns. So for focal laser, in case of CSR we use, or in case of diabetic retinopathy, non-center diabetic retinopathy like the cercinate retinopathy with the microaneurysm, to blanch the microaneurysm, so that focal laser we use. So what we do is, in order to titrate for the focal laser, we just do in the periphery first to see for the just visible one, and then we just blanch the RP. So that the grade 1 just visible one should be there, because it is very near to the center, so that the patient does not experience any scotoma. So the main point of my in this table is the depends on the grade of the burn, irrespective of the power, because the power will depend on many factors, mostly the media opacity. And also even the laser machine, practically what I have seen, the older the laser machines, the more power we have to use, because the transmission through that fiber optic cable, because the fiber optic cable also wears and tears, damages happens through the ears. So more the older the laser machine, the higher power we have to use. So newer the laser machine, the fiber optic cable is not used much, where it hasn't happened much. So lesser power we have to use. Yeah, thank you.
From then through the laser when you go to interior, moving from posterior end, if you encounter hesimedia or dense interest, you have to increase the power or switch to the other laser like red lasers. Burn intensity depends on the directly on the power and duration in inverse proportion to spot cells. In indirect delivery system, spots strictly via power and duration in indirect optimus delivery system. So, protective glass is present in laser room and check and then titrate as needed. More if you do more interior, we decrease the power, and if it's immediately opposite, we increase the power. According to the grades of the laser. So, according to anoxic retina, so there will be less demand of oxygen and vascular area, decrease the weather flow. In barrage laser, we have aim to the retinal adhesion, so that will be break. In focal infrared laser, we will directly laser to close the leaking area and capillary abrasions. So types of retinal lasers are fine retinal photocoagulation, sectoral, focal, grid, and barrage.
It's like a rule of thumb was
Is the macular lasers like focal and grid always require significant lower parameters than the peripheral laser populations. So,
Though in the peripheral retina, the retina is thin, like in barrage or in PRP, the peripheral retina, we have the aura, the retina is thin. So, use a little lesser power because the lesser power retina is thin, so with lesser power, the grade 2 and grade 1 can happen. Yeah.
coming to the fine retinal photocoagulation, we will usually do 3 settings. Area is usually we do the 1 to 2 inch diameter on the optic nerve head, superiorly and inferiorly outside the vascular arcade, and temporally 2 disc diameter away from the fovea. Usually doing 3 settings or 2 settings. Usually generally 1 setting if we are doing in the 3 settings, usually we do the 600 to 800 microns per spots per setting, and totally we do the 800 to 2400 burns. What is the main thing is the around the arteries, minimum the equator. You can do the periphery. You should aim medical with the effect.
Just to make it a more interactive, Dr. Suvarna, I just give you a case scenario. So yesterday we had one patient with proliferative diabetic retinopathy, but his along with creatinine levels, his kidney was also this thing. Creatinine level was around 1.85 higher on the higher side, and urea was 53 higher than the low higher level was 42. So creatinine level was high. So how would you suppose there's a PDR? If this is the right time. So suppose there are 2 case scenarios. If there is no vitreous hemorrhage and PDR, and if there is a PDR with vitreous hemorrhage, then we do the PRP settings. So how would you approach? Like first, which quadrant will you the laser, and second setting, or if you require third setting? So how will you proceed further?
And usually when PDR is there, we'll go for PR. Only usually in the high risk cases, we'll go for PDR. In that, usually in 3 settings. In the first setting, usually we'll cover the inferior quadrant and the nasal quadrant, because in case sometimes in lasers there can happen a vitreous hemorrhage and it can obscure the inferior quadrant. So first it is preferable to do in the inferior quadrant. And in case of vitreous hemorrhage is there, when the inferior quadrant is involved, then we can go with the superior quadrant and the temporal or basal based on where it is visible. And in yesterday's case, this will be like a patient is having high RFP values. So in that we have to minimize the laser marks. Like if we give more laser marks, there is a chance of macular edema in that cases. So better to limit the marks and keep it like more sittings in such cases.
Thank you. So, very rightly you mentioned, but like in cases of creatinine in high RFT values, the reported side effect is the exudative retinal detachment due to the retinal photopopulation. So, what the literature says is we have to minimize the number of burns, like 1000 till 1000 burns per sitting or 900 to 1000 burns, and you can increase the number of sittings in cases of high renal parameters. So, exudative retinal detachment is one of the reported complications. It resolves on its own, but when it reaches to the center, the patient will have a transient diminution of vision. So the patient gets little apprehensive and anxious. So the increase the number of sittings, and when there is no vitreous hemorrhage, go for the inferior nasal, or you can even cover the inferior full quadrant 180 degree first, and then the second sitting you can do the superior quadrant, superior half, like superior nasal, superior and temporal, and in the third sitting you can cover the peripheral. So in that way, but particularly specifically because of the high RFT levels, I wanted to mention to avoid the risk of exudative RD. So you have to space. You can do it even in 3 to 4 settings to avoid exudative retinal detachment. Thank you.
On the practical tips, first in laser we have to see the orientation, not the very summary. If you blind during the canal or any laser, first thing is to mount the orientations. Do the inferior first, reduce power in horizontal meridian, because when you put the laser in horizontal meridian, it will be in the horizontal meridian, we have to reduce the power at the level. If there is a vitreous hemorrhage, we have to increase the power, or if it not possible, if red laser was available, then we have to switch to the red lasers. Which areas macular bundles direct laser, we can do the lasers on direct and video elevated in areas of correctionals, because then if you do the laser around the correction, we are very close, there is a chance of occurring the correctional retinal detachment. So the thing is the new vascularization after we have done the PRP, like fine vessels, dilated dots or tips covered with the hemorrhage. There is a new hemorrhage is occurring, and we have to do the filling PRP. First we have to do the fundus progression angiography. We have looked for the CNP areas and skip areas, which is laser is not done. Then we have to yes.
We are blessed to have SuVi Gupta sir with us. So as he mentioned, sir, this NBI and NBA, sir, in cases of like neovascular glaucoma, sir, can you throw some light on like how to manage these cases, because these cases are very aggressive, sir. The IOP does not come under control in spite of maximal medication, sir. So like in spite of the PRP, Avastin, so usually should we do polio first, and like what are the steps? How should we help?
Yes, in case of neovascular glaucoma and new aspiration inquiries, first we have to manage the retinal part. First part we have to do is to control the retinal thing. So what is the major cause of neovascularization? We have to see and manage that part. Then we have to do the proper colonoscopy and evaluation and segment. So roughly also you can know the how much the neovascularization is. Then anti-chamber injection of plastic we also can give in this case. And then medical management of glaucoma is first choice. We can try timolol, primordial, nivolumab, all these drugs. Then we can plan for ovulation also, ovulation of this particular network. Then in the last part we can do surgery also, clinically and implant also we can with more wall implant surgery.
Thank you so much, sir, for throwing some light on neovascular glaucoma. It is a very difficult condition to treat. It is very aggressive condition. Yeah, thank you. Please continue.
Coming to central lasers, indication for central laser is the retinal branch, retinal reinforcements or ROPs or post vasculitis occlusion or radiation retinopathy or external source from case they like the retinal membrane. So generally, area of distribution for retinal population is the CNP areas, which we see on the fluorescent angiography. Important to cover all the periphery because if we don't do laser the peripheral area, there will be still the pressure load there, and there will be still vasculitis. And especially in case of vasculitis. Case of VRV, you can see there is a fluorescent angiography.
If it is showing the CNP areas, so over the CNP areas, those PRP has been done. So the practical point which you should remember is, let's see, there is a sclerosed vessel. That means it's an old vein occlusion. So sclerosed vessel will correspond to the capillary non-perfusion areas. So you have to cover the sclerosed vessel as well, and 1 to disc diameters adjacent to the sclerosed vessels also you need to cover. Okay, so by doing the central PRP or in case of old vein occlusion or a hemi PRP, and the edges of the sclerosed vessel 1 to disc diameters adjacent to the either side of the sclerosed vessel you should go, and you should go as close to the ora as possible. As possible, you can go close to the ora. Yeah, right.
Focal laser will be there is a 50% chance of reduction in risk of moderate results. What are the drawbacks of it? If we once are very close to the center of the macula, there will be the scotoma, RP and retinal atrophy, sometimes larger than the spot size, and like and encroachment fixation like the central vision is affected, color vision is also affected sometimes. Direct or focal lasers, which is done usually in diabetic macular edema, which is a focal leakage on FFO. So by doing the focal laser, we aim for this focal leaking macular edema to blanch that and close the focal leakage. So what will be the area of distribution for the laser is the three wall lesions within the 2 piece diameter of the macular center, and do not treat the lesion which is 100 micron close to the fovea. If the lesion is less than 25-40 and persistent retinal edema is present, you can go up to the 30 micron from the center. So 300 micron. Coming to grid lasers, which is usually done for diffuse macular edema. In every there will be a diffuse leakage by abnormally permeable and dilated capillaries, which is usually done 500 to 3000 microns superiorly nasal inferior in the center of the macula, and 500 to 3500 micron temple of the macula. No burns are placed within the 500 microns on the techniques. This protocol is replaced by modified lasers, which is modified. This what we do is don't treat the macular bundle. We only do the laser superior, temporal, and inferior part of the macula. Always visualize the photo of this is discuss the we can do several 50 microns leads which is necessary to close the leakage from the microaneurysms. If it's a large microaneurysm where the can treat with a large spot size also, always avoid the laser burns retinal bundles and avoid the area with spinal hemorrhage. Now coming to the barrage laser, indication usually are lattice degeneration, horseshoe tear, retinal dialysis, retinal holes.
PRP topic very nicely covered. So only thing is elevated LV, elevated fibrovascular traction. You should go practically both the tracking, away from the tracking and the elevated LV. So that by the laser scars, when the laser heals, the scar which will form, the scar which will form will not cause a traction onto the elevated LV, which can further be and which can further predisposed to more traction. On the flat NP, yesterday we had that case, the NP was flat, so we laser on the NP. So flat NP, we can laser on the NP, but the elevated and the tractional fibrovascular manifestation part to the laser close to that. And the fill in PRP. So what happens if the PRP does not have a fixed number of settings? PRP, we should wait for 6 weeks. Suppose we complete the PRP. We call the patient for follow-up after 6 weeks to see whether the NBE has regressed or not. If the NBE has regressed, so we can see those ghost vessels along the NBE, the completely sclerosed vessels. If the NBE has not regressed or more NBE has cropped up, then we have to do fill-in laser. Sometimes practically what happens, where to do fill-in, because already we have covered the full distinct lasers. So in between the laser marks also we need to do fill-in. And sometimes this laser PDR with vitreous hemorrhage also comes. So that can be due to PVD induced also, or that can be due to new NBE also. So you can fill in those laser marks. And most importantly, the diabetic retinopathy is mostly a posterior pole disease. So near the arcade, you should go closer to the arcade as possible because the VEGF concentration is higher there. And for temporally, from the disc to the macula, how much is the distance from the macula to that distance? From the disc to the macula and macula to 2 diameter temporal, you can cover those. You can do the temporary PRP till that area. So these are the scale scenarios. And one more important point in young patient with vasculitis, particularly Eales disease. Eales is very aggressive. Like in Shankar Viswasar also used to say that between the laser marks, NBs can crop up. The Eales is such aggression. So Eales should have a tight PRP, patent photocoagulation. And we should have a distinct type PRP and also give distinct anti-VEGF. So in patient with multiple NBs and multiple aggressive PDR, multiple NBs even without macular edema, so we can do a double therapy, double attack in that sense, do a PRP as well, tight PRP as well, and give an anti-VEGF also to regress the NBs. Thank you. Now coming to the balance lasers.
Usually we do the 2 to 3 row of confluent burns around the lesions, and very important to cover the marking of the lesion. So patient comes the which lesions we have to laser. Any lattice tractional holes or breaks within it, symptomatic lattice degeneration, symptoms usually like flashes and flutters. If the patient has a history of controlateral has a retinal detachment, patient is undergoing surgery like refractive surgery or cataract surgery. Latest subclinical RD, which is surrounding with subretinal fluid, is then minimum size, one-eyed patient, and possibly family history of retinal detachment, and in typical latest business including retinitis pigmentosus. Or sometimes there is a systemic syndrome like Marfan syndromes, high chance of retinal or Stickler syndrome. There is a high chance of retinal break. So if there is no traction at all, we can move the laser like these additions. For patient, I think some patient will play the some contact sports or also laser that it will also. So this is a scenario. You can see there is a large lattices. So how will you really approach this patient? This should be approached like this. You can enclose in one laser setting like this one shown in the area. This is wrong because sometimes what happens in between there is a gap, so they will. So we have to cover individual lattice possible.
Yeah, so very nice point. As much as possible, you should cover the individual lattices. And some consultants say that you can do the anterior border first because it is difficult to laser. But what happens while doing the anterior border, because the retina is thin, some patient feel a little bit of pain. It is not a completely painless procedure as we experience day in day out. So complain a little bit of pain. So cover the posterior border first, and the first you can see we can do that way also, and in between also we can mark the lines. So we can do that way also. We can mark the boundary in between, and this is posterior. For me, what I found is I have covered the posterior border first, 3 rows, and then went on to the anterior border. Because if anterior border, the patient is not cooperative, it is paining a little bit, we can always connect to the aura the posterior border. So that can be also be done. Yeah.
So there is a scenario. In picture, you see that there is a multiple lattices along the vertical area also. You can see there is a 3 lattice present in the superior-temporal area with 4 and infratemporal area. So first we have to, as mentioned by sir, start with the anterior most row. Try to laser anterior margin first. You may need a spare indentation for it. And if not possible to cover the anterior margin, extend the aura and connect with the aura. And proceed with the remaining rows. Enclose separately as much as possible. So in this case, you can do separately all the lattices. There is a 5 lattices there. And
the first one they are connected to the aura. So you can see the first one they are connected to the aura, and the rest all they are individually lasered, and they are lasered nicely. And when this is the case of lattice. We'll move on to the HST level. Achha, one more important point. Suppose Dr. Suvarna, there is at the edge of the lattice. The lattice is very anterior, and there are cobblestone degeneration is there because the cobblestone degeneration won't take up the laser. So how will we proceed further? Should we stop at that border where the cobblestone degeneration, or can we go ahead with that laser? I mean, there is a cobblestone degeneration at the edge of the lattice, and we want to connect it to the aura. But cobblestone degeneration is preventing us that laser to come because the cobblestone degeneration won't take up the laser.
So patient we can cover, we can improve the cornerstone and get the water.
Yeah. So we should go ahead on the cobblestones and there is a normal rectification, then we can connect. Because what happens sometimes the confusion like I did in my fellowship is where the cobblestone is there, so I stopped there. So my mentor told me that no, you should go ahead of the cobblestone and then connect to the other. So that is the important point because many times we see those degeneration which are because there the laser marks the RP won't take up the laser. So you should go ahead and then connect to the other.
This is another case of present of laser lattice in there is a user. You can see there is a almost 360 lattice is present. So how will you think possible, sir? Like we do the 360 barrage or like this, which is usually not right. We have to do multiple. We have to cover individual and connect to the overall person.
Sometimes in case of stickler syndrome, which is called as aura circular secondage circlage. So that is also there. But yeah, this is the better way to produce. You can do a 360-degree also, but then you need to connect to the aura. Yeah, you can do a 360 degree, but this is the better way if you can do the individual covering. And I had one patient who had in one quadrant 6 horseshoe tears there. So I covered all the 6 horseshoe tears, but still, unfortunately, he went into retinal detachment. So whenever there are horseshoe tears, are very aggressive. Whenever there are horseshoe tears, no, do a full 360-degree barrage laser. And do connect to the aura. The horseshoe tears cover and also the this normal part and do connect to the aura. And one more important point, suppose there is a lattice, there are pigmented lattice. Pigmented lattice without any symptoms you can observe. But if one eye has has undergone retinal detachment surgery, so if other eye has lattice, so sir, like we should do the laser for that other eye as well. So that for the lattices with other eye has gone into retinal detachment, so the surgery has happened. So we should do the laser for that eye, and even the family history of retinal detachment, we should laser that eye. For refractive surgery, it is the different consultants have different schools of thoughts because there is as such no study to prove that before refractive surgery, if you do the laser, this thing to it like the refractive surgery induces any PVD or attraction to cause the retinal detachment. So we do a prophylactic barrage before the refractive surgery because what happens is if after refractive surgery, if after many years anything happens to the retina or the retinal detachment happens, the patient will blame the refractive surgery because he does not understand the technicalities, this situation. So that's why we do a prophylactically. But literature-wise speaking, theoretically speaking, there are no studies to state that if you do a prophylactic barrage laser before the refractive surgery, it is related to the retinal detachment post refractive surgery. But we do it as a defensive practice.
If you extend the side and join to the aura in the possible. If you can see the picture, there is a laser band partial. What can is there? There is a lattice degeneration which can from the periphery we can so we can to connect to the aura or cover the entire margin. Most common cause of retinal detachment lattice is insufficient treatment in the anterior margin. like sir said, for a second circular prophetic laser circular to prevent the retinal detachment. Sir, it is done in like if syndrome, if there is no hole or like latest regeneration without hole, still also or if there is a some like is present in our quadrants, then we can do that and if we can if the interior water is not possible, then we can extend it to the product.
Sometimes if a dense cataract is there, instead of barrage, so we had one patient with a dense cataract and multiple lattices, so and with holes. So what we do is we did a this thing cryopexy to that area, and then we proceeded with the cataract surgery after 10 days, after 2 weeks of that cryopexy. So if there is no dense cataract, if the barrage is not possible, so we can do a cryopexy as well. And another point, suppose if the patient is not cooperative for indentation, so as ma'am mentioned that in Australia they do under sedation or GA, short GA, those barrage lasers. And studies have also reported that we have instant paracaine drops and we have literally put a speculum because the patient was not cooperative and sensitive to light, and put a speculum and we are depressed on the sclera, not on the lid margin, like on the sclera, and did the barrage. They did the barrage laser. And another study they have mentioned that one assistant is holding the lid apart and while wearing the protective goggles, and we are doing the barrage lasers. Some people like superior-temporal border. The patient head is tilted like this, and we are doing the barrage laser. So these all maneuvers are also reported. So as to cover the anterior border, because you have rightly mentioned, because these scenarios are remembered, the anterior border, if not properly lasered, there is a risk of retinal detachment is there. And one more thing is that we have to be sure excess barrage is also not good. Because excess barrage, if we do an excess barrage, there can be this thing of the vitreoretinal attraction can happen, barrage-induced iatrogenic retinal holes can also happen, and sometimes a lot of PVR changes can also happen when the lesion heals. So that is that barrage-induced these side effects can happen. So excess barrage should not be there, and in young patients, 2 to 3 rows is enough. Excess barrage should not be done. The risk of ERM formation is also there. Barrage-induced vitreoretinal traction risk is also there. And the distances from the lattices, and it is 1 to 2 disc diameter. We should not go over the lattice. And one more important point, the operculum. Sometimes the holes are associated with operculum. Operculum should not be lasered. The good thing about operculum is that vitreoretinal traction is relieved, because already the traction is relieved, it has formed an operculum, but the operculum should not be lasered.
If fresh lesion near the previous laser mark appear, we should cover the margin and explain it to the infections lasers to cover it easily. So if a pediatric patient or non-cooperative patient, we can do under the GA. If a patient is sometimes what happens in pseudophakic patients due to the PCR age effect, they will be rarely we are not able to go into the water. In that case, we can also do the cryopexy. And if there is a dense cataract or media has given the laser, we can do it after cataract surgery also. And in combined PDR and DME, we should be settings of PRP along with the macular laser, and temporal PRP we can do after 1 month.
They have mentioned temporal PRP 1 month later to avoid the macular edema induced by the PRP. Yeah.
after the laser, we should advise explain and prescribe. We should advise the system to under his must and avoid any straining, and exercise on regular follow-up and express the role of the and injection of the laser. Full effect is usually seen at least 2 months after the lasers. Patient may face a slightly decrease in vision or drop in vision after the lasers. If there will be multiple sittings, will happen. If it's not possible in one sittings or two sittings, then sometimes four sittings can also happen. And post laser describe the topical steroid injections.
Thank you. A very nice presentation, very nice, interesting case scenarios. One more patient, sir, I remember one patient was very apprehensive. She came with her young student, talent student, with her brother, and she had one isolated single lattice with holes, but वो बहुत डरी हुई थी, बहुत anxious थी actually. So whenever I used to put the lens, she squeezed her eyes and वो lens को बाहर निकल जाता था. And we tried it 2-3 times. And हमने लेटा के भी supine position पे भी tried on LIO, but she was very uncooperative. So we counseled her, and at the last, what we did is the doctor became the patient, I became the patient. And the fellow, which was she was there, she put in the contact lens on me, and she showed that this is how the contact lens will, nothing will happen, be relaxed. Then she understood that was there. So practical points like the uncooperative patients, even pediatric patients, then pediatric patient under GA, pediatric patient are not cooperative, photophobic patient, sensitive to light patient. So these are all things we can counsel them, and so that they become cooperative. So yeah, all these things should be avoid heavy weight lifting, post lasers, and PDR and Bharat we discussed it thoroughly. And for horseshoe tears they generally have this subretinal fluid associated with that. That at the edge of the horseshoe tear is a subretinal fluid. So the subretinal fluid will not take up the laser. So what we do is adjacent to the subretinal fluid, we do the laser, and we cover the horseshoe tear with 3 to 4 rolls, and we tell the patient strictly to avoid any straining or exercise any heavy weight, and we can in fact give a certificate of bed rest up to 15 days also in cases of post barrage in view of horseshoe tears. So these are the things for the retinal lasers, barrage, cryopexy, and focal lasers. Grid laser is now obsolete. Sir, आजकल तो I have not seen any patients with grid laser. Like any experience in grid laser, आपके like you've seen any patients of undergone grid laser, diabetic or focal laser? Yes.
There were some patients require sometimes grid laser also, but nowadays it is very less. Nowadays.
Only non-center DME who plant that microaneurysm focal laser is there. Grid laser nowadays, as I mentioned, but very less.
Those kids are sometimes
Focal. Dr. Sumana, any other points you remember?
Second, I have a question, sir. Like in PRP, how much extent we have to go? Like up to aura or anterior to aura? In every condition we have to go anterior to aura, or only few conditions where we should go anterior to aura?
Nice question. In the sense, because recent studies have come up which shows that even the peripheral, because earlier diabetic retinopathy is a posterior fold disease, but with the wide field angiography and optos, these investigations they have shown in the recent studies that even the peripheral VEGF has contributed to diabetic retinopathy. Because I remember one patient had come, she had only one NVE which was in the periphery, not in the posterior pole. So that NV required. So the studies have done even the peripheral. So we can go as anterior to it as possible, but the probability of the VEGF concentration still remains more in the posterior pole as compared to the periphery. But as per the recent studies, we should go as to the periphery as possible. That would be better. That would be better to replace those endings. And one more big point in cases of peripheral this thing, peripheral if we have microaneurysms or dot hemorrhages in the periphery, so always consider the ocular ischemic syndrome as well, and not in the posterior pole. If one eye has peripheral this thing, ask peripheral retinal hemorrhage, ask a history of stroke or any cardiac history, and we should consider an ocular ischemic syndrome as well. So what we do is we do an FFA and delineate the capillary non-perfusion areas and do the PRP there as a prophylactic PRP, so that the new vessels or the bleeding does not happen. So thank you, Dr. Yogesh. Very nice presentation. Thank you.